So this is the overview of the picture of this implant. You see that's a high sophisticated engineered implant with quite complex shape, with vault and with the optic, haptics with 3 foot plates on each side, and with several openings, including the central opening, which is sometimes called aquaport. And this is very important because the engineers gave really high attention to design this implant to serve the purpose. And we have had our experience since the early beginning of this implant on the market, which was somewhere, I believe, back in 2013. So it's going to be 10 years quite soon. And it's been really all positive. So here are some basic features of this implant listed, and it's a posterior phakic lens. I think the era of anterior implants is currently more or less over, with the exception of iris fixated IOLs, which still require quite large incision. And what was kind of revolution with IPCL is that it's made of hydrophilic acrylic. So this material has a proven biocompatibility on thousands, and I would say millions of IOLs from this company or from other companies also around the world. And it serves the purpose, and it actually holds its shape more reliably compared to some other materials which were early on the market according to our experience. I already mentioned the openings facilitating aqueous flow. The optic diameter is 6.2 millimeters, and it comes in a size from 11 to 14 millimeters in a really impressive optical power range from -13 up to +15, and the company is willing to really make a custom implant even outside of this wide range. And the toric version and presbyopic versions are really the sweet part of that, because we can really enlarge the portfolio of patients benefiting from this technology, which we can make spectacle free. And recommended incision size officially is 2.8 millimeters, but according to our experience, it is safely injectable through 1.8 to 2.2 millimeter incision throughout the whole power range. So that really, puts this implant on a different level of incision size compared to the other competing products. So the presbyopic version is the version I love most, and also the injectable feature through small incision I would like to also underline here. So these 2 features are really unique for this implant. So let's have a look at the video. So that's the implant, how we hold it. We put it into the cartridge facing up and very carefully close the cartridge. You fill the cartridge with the PSS and gently the implant is mounted into the eye. You can sometimes inject the leading haptics directly under the iris, but it's safely to start injecting it completely into the anterior chamber. Here you see the manipulation of the trailing haptic, the rotation of the implant, and the implant is slowly is behind the iris and center. Then we aspirate OVD, and I like to use metal cellulose, but you can also quite safely aspirate it between this phakic IOL and crystalline lens. And of course, we need to aspirate most of it, but all of it to avoid pressure spikes. We bring the pupil down and hydrate the incisions, and that's it. So it's in a way a pretty simple surgery, but it does require high skill. And I have some data to share from our pilot study on myopic population with the mean age of 27 years, 0.6 years, with somehow more females over the males, a little bit more right eyes, longer eyes as one would expect, and with the deep anterior chamber as again you would expect for myopic eyes. And I would like to mention that officially in the literature for the posterior chamber phakic lenses, the anterior chamber depth limit is 2.8 millimeters. We have been implanting this IPCL routinely into the eyes with chambers 2.6 or bigger or deeper, and it seems like this is a really safe limit. So we brought this limit a little bit down. We do the routine preoperative workout, refraction and distance corrected visual acuity, basic eye assessment of both anterior and posterior segment with white-to-white measurement on pentacam. You can also do sulcus to sulcus measurement on UBM if available, but we found it like not really practical. We do have this device available at some of our clinics, but we do not really routinely use it for IPCL measurements and implantations. Then you send the data to manufacturer or to your distributor, and they calculate the IPCL and ship the product to you. Here is the outcome of our pilot study. You know, this is a high myopic group of minus 9.5 diopters refractive error mean pre-op, and we are pretty much on target with the result, which is very nice, and the result stays just stable. And regarding the uncorrected distance visual acuity, so we are very close to 0.1 logmar, which is I think very nice, and these patients with high myopia really appreciate that. And if we look at corrected distance visual acuity, we are almost at 0 logmar, which means 1/0 or 20/20 vision, whatever we call it, and it's pretty stable here. Intraocular pressure was stable at this group, endothelial cell count also pretty stable. So that are all the features of this surgery, and so we can conclude that the IPCL became our gold standard in the following indications. It's high myopia and thin cornea, or the combination of both of them. And then we also went down and we treat the lower myopes also more frequently nowadays if we, because of whatever reason, decide not to treat them with corneal laser refractive surgery. So the two main phakic IOL innovations, which I already mentioned and which really just were the main reasons why I changed from the previous implants over to IPCL, are the micro incision, 2 millimeter incision, and I consider that really important for both from both safety perspective and also from the induced astigmatism perspective. And presbyopic phakic IOL, I think that's something which what we also need, and the market was awaiting them. And the presbyopic IPCL really delivers what was expected. So here is the presbyopic IPCL with central opening. There are both versions available. The previous version without central opening and the one with it, which is on the picture. And you see the central diffractive area, which is trifocal and which is the cause of trifocality, which we need for presbyopic correction. Here I would like to briefly mention the design of central opening, which is slightly different to the other phakic IOL on the market because of its conical shape, which should just cause less light dispersion. I think this is a smart design which just lowers the scattering of the light and lowers the risk of dysphotopsias causing by this central structure in the optic of IPCL. So regarding the diffractive technology on this presbyopic version, manufacturer can supply you with all different additions from +1 up to +3.5. And I would like to point out that we, since the beginning, use exclusively the +3 addition to all our presbyopic or even pre-presbyopic patients to compensate their presbyopia. And I think and I believe there is no need to play with all different additions, because anyhow we do not want to implant something in their eye and just exchange it 5 years down the road when their presbyopia progresses. So we straight away implant the +3 addition type of presbyopic IPCL. And the trifocal diffractive structure is created on the refractive optic of this implant with a diffractive area of 3.5 millimeters in diameter. And it's a very finite structure with step height 1.5 microns and with 0.19 microns. So something really, high precision engineering. And then the light goes where it's supposed to go and the patients can gain practical independency. So our current indications for this presbyopic version are the myopes over 35 years. So that might surprise some of you, and we really offer this implant to people who are not presbyopic yet. We explained that the presbyopia is going to hit them 5-6 years down the road. They understand that, and some of them take this option to be implanted with presbyopic version earlier, and then they can benefit from complete spectacle independency long term. Typically, we implant this phakic lens to myopes from -5 to about -19, 20 diopters of myopia, and also it can be combined with astigmatism, and because we have the toric implant available also. So I can also share the results of 20 eyes of 10 patients. Here we have presbyopic age 44 ±2.5, ranging from 38 up to 47, and we have a little bit more males, and that's a myopic population, longer eyes, ACD 3.42 and 2 years follow-up. And once again, we do exactly the same pre-op workout as we would do with the regular IPCL. And let's have a look at the video. So that was the. So here we once again see how we handle this implant. Delicate, but still afraid to inflate it. We place it into the cartridge. It's up. We place it axis active. That's eye. Quite higher. So we now aspirate most of the visible material. We do not really need to aspirate all of it, but most of it we need to aspirate, and this is just the structures. Yeah, all the lens aspirating lens crystalline. So once again, so we need to do it on all type of lenses which have no central opening. So I would like to emphasize that surgical step, that anytime you implant phakic lens which does not have a central opening, regardless of all the other openings in this design, a peripheral iridectomy is mandatory. So let's have a look at the result of this group of presbyopic IPCL implantation eye. You see the distance refraction. So once again, we are quite close to 0 over the 2 years follow-up. Uncorrected distance visual acuity very close to 0.1 in 2 years. So I think that's again very nice. And in decimal, that means like it's 0.8 2 years down the road. So for these high myopes at presbyopic age, they were really happy with the result. Corrected distance visual acuity in logMAR like almost on 0, so that's 20/20. In decimal, you see it's 0.95 mean corrected distance visual acuity, so very nice visual acuities, and so both the efficacy and safety is pretty impressive here. And if we look at the uncorrected near visual acuity, in mean it's Jaeger 1.4 in 2 years, so that really shows that these people are glass independent for reading. Also near addition, you see that 0 almost 50%, and then you see really small addition for the rest of the group. But once again, typically these patients for just the routine reading, they just use no glasses whatsoever. So cumulative distance corrective near visual acuity in Jaegers at 2 years, and once again 80% of eyes can read J1, so I think that's very nice, and 93% J4. So I think this is a very nice outcome of this presbyopic implant, and we can really promise to these people uncorrected reading long term. IOP was just normal without pressure spikes, and endothelial cell density also very nice and stable. And we also gathered some subjective satisfaction data, and all patients, according to the questionnaire, would repeat the surgery for themselves or would recommend that to their friends. 90% of them do see some halo and glare, but they all consider that halo and glare minimally disturbing. And perhaps the reason for, I would say, somehow lower, less significant problems with halo and glare is because their own lens crystalline kind of filters the halo and glare, so they typically report less halo and glare compared to our trifocal patients after refractive lens exchange. Complications intraoperatively, we had some iris bleeding from iridectomy in 5% of eyes, and postoperatively temporary pressure spikes in 10%, residual refractive error requiring laser 0%, improper sizing in this group 0%, and therefore also no cataract. And conclusion number 2, presbyopic IPCL provides really fast distance visual rehabilitation, which is comparable to the conventional IPCL. But these patients typically need 1 to 3 months of full near visual rehabilitation. So the reading comes in some of the patients somehow, slower. before they really learn how to use this new optic in their eyes. And overall, 2 years experience was very positive, and today we have much longer experience. I happen to be the first surgeon to implant presbyopic IPCL, which is really many years ago now. I think it's like 8 years or something like that. And this is an excellent indication for myopes over 35 years. So that's one of the core message here, that we do not really need to wait until they really develop presbyopia, but we can offer that technology sooner. So in this older patient group, we need to be careful because smaller pupils are more common. So the surgeon should be able to handle IPCL within the eye with a little bit smaller pupil. We also see more floppy iris syndrome here. So therefore, meticulous surgical technique is required. And despite of that, I think long-term still a higher rate of iatrogenic cataracts is expected at this age group. We have right now the time for question and answer. Is that correct, Sam?
Yes, that's correct. Thank you so much, Pavel, for your excellent presentation. It was great to see your application of IPCL and also how you've integrated it into your clinic, and also your points on, not delaying and maybe offering the IPCL presbyopic technology to your 35-year-old patients. I've actually got a question, if that's okay, while we're waiting for questions to pop up in the chat. You said you offer a +3 addition to all of your presbyopic patients. How do they adapt to that?
Yeah, well, that's a very good question, right on the target, because at the beginning, we got the first information that we would need to select, our addition according to the current addition of the patient.
Yes.
And since the beginning, I did not really like that idea. As I said, I don't feel comfortable to implant something which I'm supposed to change, 5 years down the road. So I said to myself, well, let's try to implant, the full addition and see how the patients adapt to that. Surprisingly or not, they adapt very well. And despite they have no presbyopia, like in 35 years, 38 years, they adapt to this technology. They do see a little bit more scatter of light with this diffractive technology, but they do not complain at all like they would reach too close or something like that. So I really recommend to do, with one addition straightforward to all the patients, regardless of their presbyopic status. I talked to one of the colleagues in Germany who did not have the same experience, but we do it, routinely the same all over the time. And I'm quite convinced that patients adapt to that, and there is no need to select different addition according to age or presbyopia status.
Okay, very interesting. Thank you for that. So does anyone else have any questions? I can't see any in the chat box at the moment, but if you want to raise your hands, then you can ask them directly to either Pavel, and also Tobias Otter is also available.
So I would quickly like to take this opportunity, Pavel. Thank you very much also from my side. I very much like the idea how you do it with giving the 3+ diopters in all patients. And the question is always, we are all often in the discussion which addition to choose. And since I learned from you that it works well even in younger patients, I try to encourage to be more, let's say, progressive with the addition, with the choice of the addition. And but in the end, for a lot of, and I understand this very well, it's let's say a trade-off, because lower addition has let's say a lighter fewer causes less optical side effects, let's say it that way. So some are hesitant to give more than, let's say, +2, because I think, okay, +2 only has few optical side effects. And if it's enough for the patient, it may be a better choice than giving the full power that you give. On the other side, I sometimes hear, well, sometimes it is wrong, but there's discussed if the implantation or the surgery might affect the accommodative power of the eye. It may recover, but there is sometimes the discussion if the accommodative power is weaker after the surgery. Do you have any information on that or any ideas on that?
I think that's really also excellent topic which should be researched. We did not really research anything else but the ability of these patients to read before and after the surgery, which was documented in these charts, and they all read. If I understand your question well, is that whether the implant itself, which pushes on the zonulas, can affect either increase or decrease the accommodative ability of that given eye, I don't really know. The question is if we put it in and after some years put it out, but then the age in between plays a role. So I think it's very difficult to find out. And it's also very difficult to find an optical method which would fit the clinical situation to kind of neutralize the optical effect of this implant, to find out what is the ability of that given eye to accommodate on itself without taking this phakic presbyopic IOL into consideration. So therefore, we do not know.
Yeah, in fact, so it's hard to tell. It's just a gut feeling that one might get. Yeah. But there's sometimes the fear that, let's say, a correction that's too high to the current need of the patient may be not accepted by the patient. So sometimes it's said, well, I give the highest addition that the patient accepts. But I think and your results show it that the addition, if it's too high, it causes no problem, because then the patient just uses his accommodation and the other focal point.
Exactly. That was our clinical experience, and therefore, for us, it's not, an issue anymore. We don't think about that anymore. We just do it this way. You might do all the patient 3.5 or 3 or 2.5, whatever, but it really simplified our clinical work, and the +3 seems to be the right choice for us.
Very good. Yeah, and when we started, there was often the discussion if the optical side effects might be higher than with a diffractive lens in the capsular bag, as we add more optical surfaces to the system with this lens. But also your results shows that this is not the case. So the optical side effects, so halos and glare, that do not seem to be stronger than with capsular bag trifocal lenses.
Yeah, well, yeah, it was a bit of surprise to us that actually, maybe it's also because of the trifocal design of this given optic, or the smaller diffractive diameter. Whatever it is, these patients typically complain about halo and glare much less than our trifocal patients after refractive lens exchange, and we use mostly fine vision lens, which is an excellent implant, and patients are very happy, but they do see more halo and glare compared to this phakic implant.
Yeah, very, very interesting. I think also very encouraging for everybody who is interested in offering this solution to his patients. So thank you very much again from my side.
My pleasure. Do we have more questions?
Can you hear me?
Yep. Yes, Alex. Go ahead.
Yeah, it's what's your view on the correction of hyperopia? Hyperopic patients.
Hyperopia we do quite often. There are two main limitations from my point of view. Number one, the presbyopic hyperops, and I was thinking that the presbyopic IPCL would be, an excellent solution for these young presbyopic hyperops. But currently, I think in presbyopia, we do refractive lens exchange with fine vision. That's the way to go. So we don't really treat presbyopic hyperops with phakic lens. And then number 2 limitation in hyperopia is shallow chamber. And I said our limit for anterior chamber depth is 2.6. We don't hesitate to implant in 2.6. And whenever you have 2.6 or more, you can do it. And these patients are very, very happy. We have some patients up to +10 diopters of hyperopia with this phakic lens implanted, and it works well. They are very, very happy. So we do it. We use it on both myops and hyperops, and of course we combine it with toric IOLs whenever needed. The presbyopic version we only use in myops currently.
And do you need to do a YAG or anything like that for hyperops? Or additionally, we go for a peripheral iridotomy?
Hyperopic design does not come with the center opening because the hyperopic optic is too thick in the center, and very likely that long tunnel to which is called center opening or aquaport with some other lenses, that long tower on thick optic would cause too much halos and glares. So therefore hyperopic design has no central opening, and therefore you do need to perform peripheral iridectomy or iridotomy. You can do it either with YAG or vitrectomy or whatever during the surgery. I personally prefer to do it intraoperatively with 23 gauge vitrectomy. It's very straightforward. There is no risk of cataract. There is some risk of bleeding, which is not really an issue from my experience. So you do need to perform that, and it can be done during the surgery or before the surgery, whatever you prefer.
I can add on this if you just allow. So it's true what you said. And Care Groups offers meanwhile in hyperopic IPCL up to a power of 3.5, also the central opening. So the lens is thin enough to allow the central opening up to a power of 3.5, but above this, it is too thick. But this is just in recent time that this is possible and offered.
Thank you. This company is really innovating, and that's what I like on them.
Can I ask a question
Sure.
about the age of hyperops, your patients whom you decide to do refractive lens exchange? What is the age limit, or what is your experience? How young are they?
Okay, so from 40 years onwards, I don't hesitate at all.
That's my question.
But
Yeah.
I also do refractive lens exchange for younger hyperops. If I have a hyperop who is +6 or 8,
Okay.
35 years old, then I don't hesitate and I perform that, because these patients are really happy and rewarding. If it is +2, then that's different.
Okay.
I wouldn't really do that on 35-year-old guy, so then we can think about LASIK or whatever. But refractive lens exchange on people who have what I call thick glasses, +5 or something over that, even younger than presbyopic age, I don't hesitate. Having said that, I almost do not perform refractive lens exchange on myops, because in myopic eye there is much higher risk of retinal problems. We do not really see any, problems with retina on these hyperops. So therefore, I feel really comfortable to perform refractive lens exchange on somehow younger patients with higher hyperopia.
Okay, thank you.
Do we have more questions?
Anything about endothelial counts?
Endothelial cell counts. So, well, basically healthy endothelium, and I think something like 2,500 cells per square millimeters. That differs a little bit from clinics to clinics, but I think generally normal endothelium, that's what we need. If you see an eye with an endothelial problem or with atypical shape of endothelial cells, with the lower cell count, you do not really want to be blamed that you caused it with your lens. So I would avoid these eyes. So generally healthy endothelium.
Thank you. Do we have any more questions?
I just wanted to ask, you said you're not doing IPCL presbyopia in hyperops, but in myops. How about emmetrops?
Okay, then here I am again, you know, I'm an older guy now, so I am a little bit more conservative. So I do not perform intraocular surgery to correct presbyopia on emmetropes. You can do it with this presbyopic version. There are people doing it. That's not my, you know, piece of cake. So I until recently I said for pure presbyopia with reading glasses, you know, buy cheap or expensive pair of glasses and stay happy, but don't let your eyes cut with whatever laser lens, whatever. Recently, I am quite confident with biosynthetic collagen presbyopic inlay to one non-dominant eye for this patient group, because it is very safe and highly reversible procedure. So we do that. It's still experimental. You can also consider presbyopic IPCL, you know, highly safe and reversible procedure. Some people do it. I do not do it personally.
Thank you.
Any more questions?
Thank you. I can't see any hands raised or any more comments. Does anybody have any more questions before we finish? No, I think that's everything. Well, thank you, Pavel, and thanks again to Tobias for your support. I think that's everything covered for today. But thank you all for joining us and AddVision, and together with Pavel. Your talk was excellent, and again, thank you so much. I learned a lot again. It's been a great discussion, and we hope that you have learned something new about IPCL and can see that it offers an alternative bespoke refractive solution for so many patients, especially those unsuitable for laser or with high refractive errors. Shortly, I'll send you an email with a link to some feedback. It'd be great if you could fill that in, just so we can improve for next time and know what's worked well and, you know, and what we can improve on. So again, thanks so much for your attendance, and thank you again to yourself, Pavel. It's been a great evening. Thank you.
Thank you. Also, it was my pleasure, and it was a great audience with really questions on target. Thank you so much.
Thank you. Good evening.